Thank you very much, Monica, and welcome again to the very first in this new series of the International CML Foundation Key Discussions on CML Latin America. I'm Arlene, I'll be your moderator today, and before I introduce our speakers, I'll take just a moment to introduce any newcomers here to the Foundation and tell you a little something about our work. So we are a physician and researcher-based organization with two key priorities, working towards improved outcomes for CML patients worldwide. Firstly, we are raising the bar on CML management through CML education, and that includes meetings like this. Over the last 15 years, the Foundation has been working via preceptorships, in-person meetings, and online with our case discussion forum and our knowledge center, trying to make sure that no matter where you are in the world, CML physicians and researchers have access to the best possible knowledge, opinions, and experience. The other side of our work is harnessing the power of global research. Our ideal is working towards a cure for CML, but along the way, we're trying to improve treatment pathways and patient outcomes as much as possible. So we have the Genomics Alliance, we have the TFR Alliance, we did a lot of work around CML and COVID, we have a hepatitis B survey, which is just rolled out. We're looking at pregnancy in low and middle income countries, pediatric treatment in low and middle income countries, with much, much more to come. So that's just a brief overview of the International CML Foundation, who we are and what we do. Please reach out to me if you have any questions or want to know more about our programs. Okay, so our discussion for today is CML highlights of ASH 2024 for Latin America, and I'll introduce the speakers right after doing just a little bit of logistics and housekeeping. So we want to hear your questions and your comments, but for everyone's comfort, please keep your microphones switched off until you actually wish to speak and be heard. However, it's really nice for our presenters and also for me, the moderator, to feel that we have an audience of real people out there. So it'd be lovely to keep your camera on. You can ask your questions via the chat function or raise your virtual hand. If you have logistics issues or need help, please go to our host today, Nicola Evans, and any issues with interpretations, again, send your message via chat to Monica. Okay, so I'm delighted to introduce our speakers for today. It's an all-female cast today, which has never happened before, and all very heavy hitters in the CML field. So first up today, Dr. Katia Pagnano from the Center for Hematology and Chemotherapy in the University of Campinas in Brazil, and she has chosen to discuss 3 abstracts about molecular mechanisms of resistance from ASH with particular relevance to Latin America. And I must also tell you that not only is Katia a great physician, she's an intrepid adventurer too. She's summited Mount Kilimanjaro in Tanzania in 2019, raising funds for CML research and physician support through the Foundation's Climb for Cure. And then she backed up in 2023 with a great global team, including me, to complete the Annapurna Base Camp climb in Nepal. And I'm really happy to share with you, our Latin American audience, that our next Climb for Cure will take place in the Andes in Ecuador in just over a year's time. I'm nervous already, and I hope that Katia and hopefully others of you in the audience will be able to join us on that Climb for Cure. If you're interested, please get back to me, get in touch. Our second speaker is Dr. Carla Boquimpani, also from Brazil, who heads up the heme service in the ONCOCLINICAS group in Rio de Janeiro. She's technical director in the Health Foundation Rio de Janeiro and a principal investigator in many clinical trials. She's a frequent guest on our conversations and conference meetings, and she will discuss 3 TFR papers from ASH of particular relevance to Latin America. Welcome, Carla. And our last speaker today is Dr. Carolina Pavlovsky, who heads the research department in FUNDALEU in Buenos Aires, Argentina. Carolina is a great friend of the Foundation, and she is my go-to person for anything laboratory related in the region. It's a privilege to have you here, sharing 3 key papers from ASH on new drugs, again, of particular relevance to Latin America. Okay, so I will take my slides down, and I'll invite Katia to share hers, please. So as Katia is getting her slides up, I'll let the audience know that Katia will spend 5 minutes on each of her abstracts, and then we'll open up to the audience for questions and discussion of the 3 abstracts. If you would please use the chat function to post questions as we go, as she's doing her summaries of the 3 papers, and then we'll come to those questions at the end in the discussion section. And once we've started that discussion section, you can also use your virtual hand, and I will invite you to speak. Okay, Katia, you are ready to go.
Yes, thank you, Arlene. Thank you very much for the kind introduction. Are you listening to me? Yes, it's okay. Okay, so I'd like to thank you, everybody, for being here today to discuss these abstracts that we have selected for this meeting tonight, and for the ICML for the opportunity to be here to present them to you. So these are the first 3 that were selected. The first one is a very nice work made by the Australian group. We'll talk about the strong association between cancer variants and diagnosis and the emergence of kinase domain mutations. So the aldehyde groups have previously demonstrated that in patients treated with imatinib, that 16% of these patients at diagnosis had cancer variants. And ASXL1 was the most frequently mutated gene. They found this mutation in 9% of the patients at diagnosis. And this was related to increased failure and kinase mutation domain acquisition. So the aim of this present work was to evaluate it in frontline if more potent BCR-ABL TKIs could overcome the negative impact of these cancer variants detected at diagnosis. So they made that evaluating by RNA-based hybridization next generation sequencing. They sequenced 315 patients that were consecutively treated with frontline inhibitors. And the comparison group was that group treated with imatinib in frontline. So these are the main characters of the patients. So we had 216 patients treated with second generation TKI, basically nilotinib and dasatinib, and another population, 99 patients treated with asciminib. And then they found that AXL1 was found in 6% of patients treated with second generation TKI and 9% of patients treated with imatinib. And so 20% of potent TKIs treated patients had cancer variants at diagnosis. In this figure, we can see the most frequent one, that was AXL1, that was found in 7% of the patients, and other mutations that they found at diagnosis. And what was the most interesting finding is that cancer variants at diagnosis in patients treated with more potent TKIs were associated with lower major molecular response rate, inferior failure-free survival, and they have more kinase domain acquisition in comparing with the group that has no variants at diagnosis. And the same did if we consider that separate from the cancer variants AXL1 mutation, we see that 60% of the patients achieved major molecular response, but it was inferior of the group that has no cancer variants. And also they had patients with XL1 other variants. They had inferior failure-free survival and higher rate of mutation acquisition. We can see here this detail. So they have an inferior outcome. And the same for patients treated with second generation TKI. Patients treated with Nilo or DASA, they had no difference in terms of major molecular response, but they had an inferior failure-free survival, and also they had more mutations, BCR-ABL mutations acquisition than patients that has no variants or no XL1 mutation. And the same with asciminib. Even asciminib was not able to overcome the poor prognosis that this mutation confers to CML patients. These patients, they had inferior failure, a higher rate of failure-free survival, 33%, and the 56% of them achieved kinase domain, BCR-ABL kinase domain during the follow-up. So when they evaluated the AXL1 mutation at diagnosis and the acquisition of mutations, we see that 29% of patients that has AXL1 mutation variants at diagnosis develop BCR-ABL mutations by 2 years. And on the other hand, only 3% of patients that had no variants develop these BCR-ABL kinase domain mutations. So the main findings of this abstract was that patients treated with AXL1 is the most relevant cancer variant found at diagnosis. 80% of the patient has this variant. And this variant has a negative impact and it was not overcome with frontline more potent BCR-ABL therapy, even if with asciminib the outcome was inferior. So this opened room for a potential benefit for combination therapy in this cohort of patients, where the risk of treatment failure is driven by kinase domain mutations. So in this other abstract that we selected was about the combination of asciminib with other ATP competing TKI in order to try to overcome the negative impact of these mutations. So this was a work developed by the German group. They found that 20 to 30% of newly diagnosed patients with CML has other mutations, unless others than BCR-ABL. And they also find that the patients that has AXL1 mutations at diagnosis had an inferior major molecular response. So in this work, they try to evaluate the impact of these additional mutations in newly diagnosed patients treated in this clinical trial that's called Fascination Study. It is a frontline asciminib combination study, a phase 2 trial, where asciminib was combined with other TKI, as I'm going to show you in this picture. So the design of the study is this. There are groups treated with nilotinib, dasatinib, and imatinib in frontline. And after 12 weeks of treatment, all these groups were combined with asciminib in different doses. And the primary objective of the study was to evaluate the patients that reached MR4 at 24 months with the aim to reach TFR. So patients that achieved deep molecular response, a group persisted with the 2 combination therapy, and another group with only asciminib monotherapy. And the group that has no achievement of MR4 remained with TKI monotherapy. So they evaluated 144 patients recruited from 20 sites in Germany, with the median age at diagnosis at 45, and 125 started the combination therapy with asciminib, and they studied by next generation sequencing 24 myeloid leukemia associated genes. And they found that at diagnosis, 18% of the patients carried mutations in addition to BCR-ABL. And the mutation status was correlated with the primary endpoint of the study, that was the rate of MR4 at month 12. So we see that the most frequent mutation was, like the Australian group, was AXL1. They had mutation in 6% of the patients. And even patients with low ELTS score have the mutation. 4 of these patients with low score had AXL1 mutation. So they found that MR4 was reached by 38% of the patients at 12 months. And they found that patients that carried AXL1 mutation at diagnosis didn't show a different MMR probability than patients without the mutations, different from the other data that I showed you before. So 88% of the patients achieved a major molecular response at 12 months. And the same happened even with AXL1 mutations. Those patients, they had 75% of probability to reach MMR at 12 months. And this was clinically significant. So in conclusion, in conclusion, AXL1 mutation was the most frequent mutation found in this work. And patients that carried this mutation showed an inferior molecular response to nilotinib in the TIGER study, but not in this study that used a combination of TKIs. So the combination of asciminib with other ATP competing drugs was able to overcome the negative impact of the AXL1 mutation with regarding to molecular response. We still don't know at long-term follow-up, and the optimal therapy for these patients still needs to be defined in future studies. And finally, this work I selected because it's what I work for my group, and that we studied a very relevant concern that we had about the changing of the classification of CML. We all know that the latest edition of the WHO classification has omitted the definition of accelerated phase, because now the prognosis of accelerated phase was improved with the TKI treatment. And now it's more important the high-risk features at diagnosis that are associated with progression of chronic phase. However, the international consensus classification maintained the definition of accelerated phase. So our work was to evaluate in real world what was the impact of this change in classification on prognosis of CML patients treated with imatinib in the first line. It was a retrospective study conducted in a university hospital. We analyzed patients diagnosed between 2015 and December 23. We collect data from newly diagnosed patients and classified according to the new older version of WHO, 2002 WHO and the ICC classification. The patients were treated with imatinib 406 milligrams a day, generic imatinib, and cases that had not sufficient data to analyze were excluded. So we evaluated 139 patients treated with imatinib in first line. 2 patients died before starting imatinib, and the others started imatinib in a median time of 10 days, and the median follow-up was 39 months. So according to the WHO classification at ICC 22, 90% were in chronic phase, 6% in accelerated phase, and 4% in blast crisis. According to WHO, where accelerated phase was omitted, we had now 96% of patients in chronic phase. So we had a change of classification in 6% of our patients. These are the clinical characteristics. Median age 53. Most of the patients were male, females, 51%. And we had the majority of the patients, not majority, but a high number, a third of the patients were high-risk SOCO and high-risk ALTS. We had a treatment response of 47% achieved major molecular response. And from these patients that were reclassified as chronic phase, these 8 patients, 5 of them had to switch to a second-generation TKI because of failure, and 2 of them required allogeneic stem cell transplantation. 1 died from the procedure. The other patient progressed to blast crisis, and there was 1 loss of follow-up, and 4 patients are still alive. We had, in this group, 68% of death related to CML. So we can see in this picture the overall survival by WHO 2017 and 2022 pretty much the same, even if we exclude the accelerated phase, and progression-free survival the same. We didn't see any significant difference here. So in the multivariate analysis, the independent factors for overall survival was the count of basophils, the phase by WHO 2002, and the age of TKI start. And for progression-free survival, WHO classification, and age at diagnosis. In conclusion, the omission of accelerated phase in the new WHO classification did not impact significantly in our cohort of patients in terms of overall survival and progression-free survival. And the factors related to worse outcomes were age, higher basophil counts, advanced disease. But the challenge that the challenge that the omission of accelerated phase may represent for us is that we cannot use higher doses of imatinib in patients classified as chronic phase, because also in Brazil we have a situation that we don't have second generation TKI to be used in first line in the public system. So the problem of the reimbursement may happen also in other countries, and this I think it's a good thing to be discussed here. Thank you very much for your attention. I'm glad to answer your questions. Thank you.
Thank you very much, Katia. lovely papers. They're extremely well chosen and well targeted. Who would like to engage Katia in some discussion about her abstracts?
Are there any questions in the chat or not? Still not? Yes, maybe someone.
So I'm looking for virtual hands.
Not so. Please don't be shy.
Carla, would you like to start the ball rolling, please? Thanks, Carla.
Yes. Katia, about fascination study, what do you think that could change our treatment in first line? Do you think that this could be a good idea to add the other drugs? What do you think about this? This could be real for us.
Yes, let's talk about possibilities first, because we still don't have a longer follow-up, right? They show that we have a major molecular response in those patients that had a worse prognosis, but we still don't have a longer follow-up about survival, if this will be different from that all the data that we have about, for example, in terms this imatinib compared to second generation TKIs, there is no difference in the long-term follow-up from progression-free survival or overall survival. But I think it could be an idea for this group with this that has a worse outcome. But I think this has to be studied in clinical trials like fascination that will be able to answer if those patients will be able to have a more rate of discontinuation in the future, and also a longer survival. They achieve a response more rapidly. As you see, 88% achieved response in the first 3 months. Patients that had the IXL1 mutation. So it looks promising, in my opinion.
I agree with you if you think that using expensive treatments during a short time and not so less expensive during all day life. But what do you think that could be used after the patient failure to TFR? This is a big problem, okay?
Yes, this is a very nice question, because we still have to deal, not all patients will be able to stop treatment and stay in TFR. So we still have the problem of the long-term treatment for many, many patients. And that we have to pick the most, the TKI that has less adverse events, that's more tolerated by the patient.
Yes, thank you.
I would like to make a comment on Katia's on a question, because we are in a LATAM audience, no? And you have mentioned the ASXL1 mutation. It's fascinating to see those results, and it would be fascinating to make this mutation in our patients, in our real world patients, no? Do you think that it would be a moment that we can, in a very near moment, that we can include this NGS in our routine practice? Do you? I think you are not doing it, but I ask you if you do it outside clinical trials, and what's your vision of this?
Well, in our practice here, we don't have access for NGS for all the patients. It's still only in research. And even if you look at the guidelines of the recommendation, everybody is still reticent to recommend NGS in clinical practice, because all the researchers, they want to learn more before saying that we have to do NGS for everybody a diagnosis. I think it's still in research, in the research setting, but with a perspective of being a near future application. And yes, as they showed, that not every patient has the variance diagnosis, and so I think it has to be cost effective, mainly for us in Latin America, that we have limited resources. Virginia.
Just to reinforce that comment, I think it's too early to make any recommendations. And the only way these studies will be cost effective, we can select patients with them to select the right TKI to discontinuation. I think it's too early, but the study is really, really interesting. But until we see data on survival, I think for Latin America at least, and in Colombia, this is unthinkable. First line treatment with that until we see any results on terms of survival. It's going to be very, very difficult.
Yes, more evidence is needed. I agree with you.
Katia, I have a sort of general question. Having just been to ASH, in fact, everyone, all of you who did go to ASH, what do you see as being the most promising areas of research in CML right now, especially with a view to clinical need? What really, beyond the presentations, the abstracts that you presented, what are the most exciting bits of research at the moment?
Yes, one of them that we're talking about selecting more the patients to know the patient that has worse prognosis. They are high-risk patients, and for this group of high-risk patients to evaluate which treatment will go better. Now we have, Carolina will talk later, we have a lot of new drugs that are being developed. So I think we have many different ways to explore that, joining what we know in molecular biology of the disease, and try to deepen the response and to increase the chance of the patient to be in TFR and for the cure of the disease. Yeah, I think it's going this way, in my opinion.
Super. Thank you very much, Katia.
Last
Any more questions out there for Katia? Not at the moment. If you think of something, we will have a few minutes at the end of the session. Thank you very much, Katia. That was great. Excellent abstracts. Very, very interesting. Thank you so much. Might I ask Carla, please, to share your slides? And whilst Carla's getting her slides up, I'll just let the audience know that we will run Carla's session similar to the last one. She has 3 TFR papers that she will present. She will summarize all of them, and then we'll move to an open discussion at the end. Please feel free, if you think of questions or comments as you go, use the chat function and we'll come back to them in the discussion, or use your virtual hand or the chat function in the discussion. Please don't be shy. We want to hear you. We want these sessions to be interactive, and they are for everyone to engage. Carla, you're good to go.
Good evening. It's a great pleasure to be here. Thank you so much for this invitation. Thank you, Katia. Thank you, Arlene. Thank you, Nicola. Thank you, Avolas, and Carolina too. And I will speak about the ASH highlights, and the theme was TFR, treatment for remission. Then the first paper that I will speak about was an oral presentation. It's about the study about the cytokines inflammatory that was increased in plasma and were associated with sustained treatment for remission. I'd like to thank so much to Ihab and Professor Ihab and Professor David Ross and Professor Chung to send me the presentation. And this is very interesting, this work, because this work would like to show the differentiation about the influence the cytokines in the TFR. As background, we know that population of immunocell are very important to us in association with TFR. The cytokines are important to control the immune function, and there were a paper very important from Carolina Pavlovsky. Thank you so much, Carolina. Is a great work from Argentina STOP trial, and about the elevated plasma level of interleukin-6 and MCP reported to predict the TFR. Then, as we know about this immunofunction and the cytokines, they did a work using 2 independent populations. One population from Adelaide TFR cohort and another population using the US-less study for validation, the first study. Then very interesting, we can see that they achieved 2 cohorts, and they called the name cold cohorts and hot cohorts. Depends on the cytokines that are used, and they could show that the cluster or the hot cluster, about 73% of the patients achieve the probability to sustain MMR, and so different from cluster the cold cluster, the cluster blue, that we can achieve that only 39% of the patients achieve the probability to sustain MMR. Then if the patient are in the cluster, the hot cluster, could achieve more probability to TFR, because they achieved the deeper molecular response. This cluster was not associated with any clinical feature or the treatment used. Then, as you can see, independent of age at diagnosis of female or sex or transcript type or the prognosis, LTS, or the TKI used, any of them important points that you are using all the time to think about the prognosis of TFR, any of them were important in cold or hot cluster. You can see that there is no importance, the TKI duration or the deeper molecular response. This is very interesting, because the importance was the cold or hot cohorts, and you can see that these were a prognosis independent. Then these independent cohorts, if hot, these patients achieved 76% of the success in sustained TFR. This is the other cohort that used validation, and the validation the same percentage. 39% of the cold cohort achieved the sustained TFR. Then this is very interesting. Use this cohort or the cytokines to achieve the principal value prognosis to TFR. And these cohorts, or Australian cohorts or USA less study, they used the same cytokines. Then the only two cytokines in group Australian or US less, but no individual cytokine was important to predictive the TFR. And the group of the cytokines were important to do this. The univariate analysis was not important. Then besides to age of at TKI cessation, or the transcript, or the halving time, they only was the univariate analysis, but the TKI duration and the deeper molecular response were not important. And we can see that is a cluster was an independent predictor to TFR in the multivariate analysis. Then the cluster was more important than the deeper molecular response or the duration of using TKI. The conclusion of this work is that the plasma cytokine is associated with TFR independent of the predictors, the clinical predictors. Then, but we need more study about this, but this work was very, very interesting. The other paper that is abstract, I'd like to thank Soverina too, Simona Soverina, that sent the presentation, is about XL1 mutation. As Katia said about the importance of this XL1 mutation, we know that this mutation is related to a poor prognosis. Then they think about if very interesting to achieve identify if this mutation could be achieved in the first, before start the drug, if the mutation was positive, XL mutation, then we can see if the patient will be worse than the patient that were not mutation. Then, as Katia says, if this could be used to do associate with other drug. They used the background about the mutation, the importance of the mutation, and the studies about XL1 gene, as Katia said, and the thinking about this importance of this mutation in the prognosis of the patient. They used the sustaining study. This study was a prospective clinical trial that randomized the patients, the new diagnosed patients, using nilotinib or imatinib and switch to nilotinib in case of no optimal response. And they used this cohort to choose some of the patients, and the research is about the XL1 mutation. 124 patients did this exam. The XL1 mutation were detected in 70% of these patients, 124, 70% of them. These patients were younger, no relation was observed with gender or prognosis, and it's fast too, sorry for this, and the prognosis or the transcript. The deeper molecular response is the same if with mutation or without mutation. This is very interesting because the presence of XL1 mutation didn't any difference between the prognosis. Then a similar presentation for XL1 mutated or unmutated, the patients become eligible to TFR or not. Then this is no difference between PFS or overall survival. Any difference with or without XL mutation. Then we could think that could be very interesting to know about the mutation, but this work, they showed that did not impact on the depth of molecular response or TFR eligibility using the patients about having mutation, XL mutation or no. Then, of course, we need more study about this, but it's not necessary to see the XL mutation or to do this exam, because it's not important to the success of TFR. In the last study is the poster 2. This poster, I'd like to thank Dr. Carmen Fava through the Katia that's asking her to give me. Thank you so much. Then is a work about the registry of in Italy registry, 673 patients that included in the observational study about TFR. Then this is the characteristics of the patients. Patients using imatinib or second or third generation, and all these patients were included in the TFR group. And we can see the line of the treatments. Then patients using imatinib in first line or second or third line % of the patients, and they use the duration and the total duration TKI and the deeper molecular response. Then the duration and the deeper molecular response were the most important thing about the TFR. They use all these drugs, including ponatinib, including bosutinib, and they were included in the TFR program. And as you can see, the many patients in major molecular response or less than major molecular response, and about the response was not so good. The analysis multivariated. The more important for it was the less CKI, the duration of TMR, the level of response, the molecular response in the moment of stop. And we can see this group very interesting because MR 4.5 was better, the statistical significance when compared to MR 4. Then this is very interesting because we can see that MR4 was worse than MR4.5, and we can see the curve are the same, but they achieved a very good percentage of the patients in the outcome in 10 years, the patients went TFR in this cohort. The median time to restart treatment was 5 months. This is the percentage of the drug used, and 85% of the patients restart with the same TKI. They was going before discontinuation, and one patient restart treatment with asciminib monotherapy. The most important thing is that no patient progressed. Then we, as conclusion of this registry, in this study, 283 patients, we confirmed the importance of duration of the treatment and the type of TKI as prognosis for TFR maintenance, and the importance of the deeper molecular response achieving principal MR 4.5 in comparison to MR 4.0. They think that we need to explore other ALEX aims in the early detection of who patients will be more success in criteria to our TFR. Then I'd like to thank, this is Rio de Janeiro, my city. Then thank you so much for this group, and questions I will be available.
Fantastic. Thank you so much, Carla. Another 3 great choices there of TFR-related papers with particular relevance to Latin America. So as others are thinking about what they might like to ask, Lillian Pillow from Chile has asked a question in the chat. She says, in the TFR and cytokine study, when were the determinations done, beginning or more than one level during TFR? Carla.
They did this cytokine before the TFR. I don't understand so much, more than yes. Before the TFR, they chose the clusters, and these patients that the importance was the patients that will achieve the criteria to TFR. They didn't stop the drug yet, but the importance is the patients that will achieve the deeper molecular response. And the cluster, the hot cluster, was better than the cold cluster.
I was thinking about that maybe the patients in the hot group, in the hot cluster, could have a higher level after stopping. So that was why I was asking if the levels were taken afterwards.
Yes, the hot clusters, did you see that we used 2 studies? In the Australian study, they choose the hot clusters, and these patients' hot cluster achieve more MMR and more deeper molecular response after, and the permanent deeper molecular response to achieving criteria to TFR. In the US, they use the cluster, hot cluster, to achieve success in TFR, but the same percentage. Did you see? 7%, 73% against 39% in the cold cluster.
Okay, thank you.
Thank you, Lillian. And Ana Inés Varela, very interesting, congratulations. Carla, was there any investigation or comment from investigators about clinical socioeconomic characteristics of patients in the hot-cold cytokine cohorts? And at what time was cytokine profile investigated? Only before stopping or at more time points?
In the word, the presentation, I didn't see anything about the socioeconomic characteristic. They didn't speak about this. And the time point, I think that we told about this. What time point was the cytokine prophylactic investigate? I think that's before the success or not in the TFR. I think so. I didn't see any specific time.
Okay, there is one hand there, but I can't see who it is.
It's me. It's me, Arlene.
Katia.
Can I talk?
Yes, of course.
Okay. No, just a comment, Carla. When I saw all the three presentations about AXL1, I realized that we really need to study more that, because you see that the results from the Italian group was different from the German group. So it is still controversial, and that maybe it's still premature to make any decision based on this mutation yet. Maybe it's a question of a selection of other variables too that we can see, but it's still something to be studied and followed. What's your opinion?
I agree about this. I think the this exam only in research. I don't know if we are doing this exam in Campinas. I don't know if it's possible to do this search, but for us is it's not so close to have access to this exam. Then my opinion that in these two groups, I confess that it's we hope that AXL1 could be a great factor to separate these groups, high risk and low risk, but not in this study. But I agree that we need more time to do this. But it was very interesting to not shoot the success to TFR if not having, because we think that if the patients don't have the AXL1 could be success to TFR, but this is not what happen.
No, there are only 9% of the patients, say 8-9%. So it's not for, yeah.
Mariana Lorenzo.
Hi, Mariana.
Hi, thank you for your presentations. I have a question, or more like a comment on TFR. It seems like we need to look up to the lymphoid compartment to predict more efficiently which patients are going to stay in TFR. That data that Carla was talking about cytokines, I mean, that's a whole new story. We are not looking at the myeloid mutations or the myeloid compartment or the behavior of the disease. We are looking at the lymphoid compartment. So I don't know if your comments or if there is any data on lymphoid subsets and other studies about immune system in TFR.
Yeah, this immune system are studied for not for TFR but for CML in a long time. Only when we use interferon, then we can see that the patients that had used interferon the last time, this patient could have achieved more success in TFR. If you remember about STIM, the stopimatinib, then the use of interferon was very interesting at that time. But nowadays, any of the patients are using interferon more. We can not do this, but this showed that the immune system is very, very important. The success of the treatment of CML and the immune system is related to TFR2. Then yes, this is very, very important. The immune system is very important to success of TFR.
Katia, I see your hand this time. It's the same color as your background.
Yeah, no, just a comment to what Mariana said. It's very important because certainly the immune system has a big role in keeping the TFR. In the Brazilian group, we have a trial that is running, a TFR trial that's running, and that we are studying that in a de-escalation trial. There's a period that the patient stays half of the dose of the TKI before the discontinuation. And the flow cytometry part is being conducted by Lorena Lobo in the University of Ribeirão Preto, and they found very interesting preliminary results about different subtypes of lymphocytes and NK cells. So this certainly will help in the future to evaluate which patient will be more able to discontinue, because now we have only clinical data to decide the discontinuation. But I think one of those clinical characters that we consider is the achieving MR4.5. I always believed in that, and now Carla showed me in the Italian group poster that it really has a great importance for the success of TFR.
I think that all of us, we need to know who patients at beginning the treatment will have a very good response. Then thinking about the immune system, as Katia said, could be a good idea, but we are looking for this. This is not true yet, but I think that in a few time we can choose this.
Just a comment about what you have said. Not gonna talk.
Yes.
That when you mentioned the paper, our paper, really we measured the cytokines at baseline and at month at month 3 also, but what we published, it was at baseline, and what we saw there, the conclusion was that the interleukin 6 and the MCP, that are the monocytes, chemioattractant proteins, when they were with a low expression, those patients showed a worse prognosis, more possibilities, or were at higher risk of relapse. So it was really very interesting. It was very interesting, but it's not possible to do it in real world. And as you have said, Carla, for me, the best thing is to combine clinical variables with immunological variables, so as to have like a tree, a study tree to come to take conclusions. But unfortunately, this is very difficult, and you have seen this in the French study. They start studying this, and then they didn't continue with these conclusions.
Yes. Have a last comment on that, Carla?
Yes, Carolina is all right. We need to achieve the factors that could be assessed in all the countries. Then this exam is so difficult, and then we will be able to understand that it's very important to know the cytokines, but this is not accessible for all the patients. It's very important to achieve these factors. I think that all of us are looking for a factor that could separate the population. These patients will be very good, then this patient will be worse. We don't know now which patients in TFR, why some patients TFR need to restart the drug and some patients no. Then we don't know.
We want a TFR calculator. We want a TFR calculator, and then you put all the data, and then we say yes or no.
But the same patient that used the drug during more than 5 years, used the drug and achieved the deeper molecular response during more than 2 years, and 4.5 MR, 4.5, but 50% has success, 50% has failure. Why? We don't know this question.
A great question to end on, I think, and work for all of us, including at the foundation, to pick that up. Thank you so much, Carla. That was great. Carolina, can you please try and share your slides? We had some problems with Carolina's slides earlier. Let's give them a go. And if you can't share them, I will do it for you.
No, I can't. I don't know what's happening. If you can share it for me, it's better.
Sure. Okay, let me find them. Okay. And from the beginning, okay. Okay, Carolina, thank you. I will share your slides for you. Just let me know when you want them to move if I'm a bit slow. Carolina Pavlovsky, the floor is yours.
Okay, thank you, Arlene. Thank you very much for this invitation. And it's a pleasure to have the LATAM audience here today. For us, it's at night, so it's a great effort for the one who are hearing us. So I'm going to present 3 abstracts, 3 works. One is the Ask for First study presented by Dr. Jorge Cortés. The other one is about the second line olverembatinib for CML patients. And the last one, it's a downgrading impact project, an Italian project that is really interesting to mention. The next one. The next one.
Yeah, I'm trying. Oh, there we go.
Sorry. So I'm going to present the phase 3 Ask for First study, the results in patients with newly diagnosed CML receiving asciminib or investigator-selected TKI. These were newly diagnosed patients, and as you can see, the patients were randomized to asciminib 800 milligrams, and they were compared and stratified versus imatinib and versus second generation TKI. Asciminib was compared with all TKI and then also with only with imatinib in one instance, that was one stratum, and with second generation TKI in the other stratum. The primary objective was the MMR at week 48, but now we're going to present the key secondary endpoint, that's the MMR at week 96. The next one. So, yes, and this is the results of the MMR rates at different time points. At the left, you can see we're going to focus in the key secondary endpoint, where we can see that the results of asciminib and the obtainance of MMR was 74% with asciminib versus 52% with all the TKI. So this was a statistical difference, an important difference, with a 22% of difference. When you see in the middle bars, you can see the comparison between asciminib and inside the green box, the asciminib that the patients obtained 76% of MMR versus 47% of MMR when we compared only with the imatinib population. So this is a huge difference, also and statistically difference. But when it was compared with the second generation TKI, that was very interesting, this comparison, although this study was not designed to compare to the second generation TKI, it was observed that the difference was increased when you compared the 48 months and when we compared the secondary endpoint that it's at 96 months. So it was a difference of 8%, and now the difference is of 15%. So we have to wait, obviously, for time. The next. And here we can see the deep molecular response at week 96. Also comparing, if you make a click, again, you can see, that's all. We can see the patients that were compared asciminib versus all the TKI. 30% of the patients with asciminib obtained deep molecular response, 4.5 of molecular response, and perhaps only 17 patients achieved deep molecular response, 4.5. This 17 includes all the patients, no, 17%. When we divide and we discriminate, and you can see in the middle of in the boxes, the graph of the middle, you can see that 35% of the patients with asciminib obtained deep molecular response 4.5 when it was compared with imatinib, and the imatinib percentage was 11%. So this here we can see an important difference. And we continue with the same, what I have mentioned in the slides before. With the second generation TKI, you can see that the difference perhaps is not statistical, but there is an important difference in this deep molecular response. So you can pass the next one. Here we can see the Kaplan-Meier curves. Mostly what's important is to see that the cumulative incidence of deep molecular response was higher with asciminib than with all the TKI. So in green, you can see the patients with asciminib, and in blue, pale blue, the patients with all the TKI at the left in the top, and at the right in the top, you can see the differences between asciminib and imatinib. Also, this was an important difference, and asciminib showed higher deep molecular responses than imatinib. The difference was not seen when it was compared with the second generation TKI. The next one. And this is an important table and a difficult table perhaps because they have published, Dr. Cortez mentioned the post-baseline treatment emergent BCR-ABL mutations by NGS, and we noticed, and it was described, that 10 patients had post-baseline mutations, and these 10 patients that were receiving asciminib had post-baseline mutations that were present in the myristoyl pocket. And what happened? These patients discontinued the asciminib because they were mostly resistant or had an unsatisfactory therapeutic effect. But as you can see, after discontinuation after going out of the protocol, post-protocol therapy was a second generation TKI. That's important, and in this case, mostly dasatinib was selected. And the patients, some of them had data lost because they discontinued the study. Some of the patients are in chronic phase and alive, and one patient had a blast phase and died. The next one. The next one, just to make here. The most relevant adverse events with asciminib versus all the TKI are seen here in this graph. In green, we can see the asciminib adverse events, and in deep green, the grade 4, the grade more than 3, that is what we are all concerned about. And 13% of the patients had thrombocytopenia with asciminib, 10% neutropenia, and very little elevation of the hepatic enzymes compared to all the TKIs that also had and showed 10% of thrombocytopenia, more neutropenia than asciminib, 17%, leukopenia, and 5% of ALT increased. And also lipase, well, the lipase is practically the same. The next one. Here is the difference between the different stratus. We can see with imatinib, the comparison with imatinib, and perhaps you can focus on the graph below. You can see the asciminib, as I have mentioned, 13% thrombocytopenia, and with second generation TKI, we can see 10% and 17%. So mostly the hematologic adverse events were because of the second generation TKI, what I have described before. No, the next one. It's also important to mention that it was described many patients, 7 patients had arterial occlusive events, but when you look at the history of those patients, they were 2 young patients, or more than all the patients had more than 50 years old, and 2 were less than 50 years old. The majority had a high risk Framingham score, and cardiovascular risk factors. But there were 2 patients that didn't have cardiovascular risk factor. These patients had cardiovascular arterial-occlusive events, but as you can see, they were described as grade 1, many of them, with the exception of 2 of the patients that have cerebrovascular accident with asciminib and myocardial infarction with dasatinib. The next one. And this is the description of the patients who died because of complications post-transplant or metastatic bronchial carcinoma or gastric cancer and core pulmonar, or the last one is progression of a blast crisis. Next one. So the asciminib, as summary, we can say that continue to demonstrate superior efficacy versus all the TKI and MMR rates as high as 76%. This was observed when compared with the imatinib stratum. The treatment difference for MMR rates increased from 8 to 15 at 96 weeks. That was what I mentioned. It was not, when compared with the second generation TKI, not statistically significant, but yes, doubling the possibility to have a deeper molecular response. And deep molecular response rate at week 96 remained higher with asciminib than all the other TKI. So after longer follow-up, asciminib's safety and tolerability profile continued to be better than those of imatinib and second generation TKI and consistent with its own safety profile, known safety profile. So asciminib favorable benefit risk profile compared with the TKI we know in patients with newly diagnosed CML reinforces its use as a standard of care for this patient population. So this is the end of the first abstract, and I'm going to present now the second one about olverembatinib, a second-line therapy in patients with CML chronic phase. This was presented by Dr. Weiming Li, and the next one. This first one, first of all, I would like to mention that olverembatinib is a third-generation TKI, BCR-ABA TKI that has demonstrated remarkably efficacy and a favorable safety profile in patients with CML resistant and intolerant to at least 2 TKIs or those harboring T315I. So the aim of the study is different because it assesses the efficacy and safety of olverembatinib as a second line in patients without the T315I mutation. So here we can see the design of the trial. The patients were included if they have received 1 line of TKI, were resistant or intolerant, and they received olverembatinib at 40 milligrams every other day. The primary endpoint was CCYR, and the secondary molecular MMRs, complete hematologic response, and also survival. The next one. The next one, if you want to pass it, this one, the next. That's all. Here we can see, and it's interesting to see that the patients who entered the study were mostly resistant. 93% of the patients were resistant, and 74% of the patients didn't have a mutation detected. That's also interesting. And mostly there were 4 patients. No, there were 6 mutations that have been described. The next one. Here we can see the different treatments the patients have done previously. You can see at the left, the imatinib, the patients who had done imatinib previously to enter the study, and those who had started second generation TKI who have been resistant and that then receive olverembatinib. So as you can see, 78% of the patients who were resistant to second generation TKI and received this drug achieved a CCYR and 43% MMR. So this is an important response in patients who had received a second generation a second generation treatment in first line. Of 9 patients pretreated with imatinib, 50% achieved CCYR and 33 MMR. The next, I think I have another. No, yes. Here is the best response with olverembatinib, and we can see that 74% of the patients, these are second line, no? 74 achieve CCYR, and 40, nearly half of the patients, MMR. The next one. And here we can see that when patients, this is interesting because when the patients were grouped into two groups, not according to the baseline percentage of transcripts. So those patients who had more than 10% at baseline showed that achieved CCR in 69% of the patients, and those who had more than 10% achieve 37% of those patients achieve MMR. So it's like an adverse prognostic factor, but although this occurred, the patients achieve, a high number of patients achieve good responses. The next one. This is the graph that it's related to the mutation status. At the left, you can see the patients without mutations. They were not patients 24 only, but here we can see those with no mutations compared the ones that had mutations. Inside the group of the patients who had mutations, the T315 it was not included. So the patients who had mutations showed to have better results, better CCYR and MMR. As you can see, 85% of these patients achieve CCYR and 55 MMR. Better results than those patients who didn't have a mutation. The next one. And this is interesting because they describe the adverse events, and as you can see, many patients, really between 40 and 50% of the patients, had thrombocytopenia grade 3-4, this is important, and anemia approximately in 10%, neutropenia in 30%. So the hematological adverse events were the ones who appeared and who were most described in these severe grades. The next one. So this is the first report of olverembatinib administered as second line, and it demonstrated remarkable efficacy in patients with chronic phase without T315I mutations. And this drug resulted in CCYA rates of 74% and nearly half of the patients, 40%, in MMR. So no new safety signals emerged with this drug treatment as compared with those previously reported. And this preliminary data suggested that olverembatinib may be a viable second-line treatment option for patients in chronic space, especially for those who experience failure on first-line, second-generation TKI. I think, well, I have this one, that's the last one. And here we have the Elisabetta Brussese interesting presentation about assessment of transitioning from high potency to low potency inhibitors in CML patients. The downgrading impact project, a CML campus study, the Italian group, no? So this here, this is to introduce. She mentions that it's important, and everybody knows that the CML diagnosis has like two objectives: the long-term therapy and the TFR. And when you have a patient within long-term therapy, there is always generally dosage modulation, and approximately the objective and the sustainability of the downgrading. She described was first increase the TFR remission success, then the reduction of toxicity in the medium long term, and what is interesting here is the third objective, that is cost and sustainability. The next one. So The evaluation, the objectives was to evaluate the frequency of switching from higher potency inhibitors to lower potency inhibitors, identify the categories of these patients, analyze the reasons that led to the downgrading, and evaluate the outcome. The patients that were included were those patients with CML on therapy with second generation TKI or higher, and patients who have undergone a change of therapy from a higher potency inhibitor to a lower potency inhibitor. Here we have some surveys, in this survey, some data about the what she collected, outcomes, TKI before, after downgrading. But what's important to say here is that she identified 157 patients that were the ones who were eligible for the analysis. The next one. Here we can see that the duration of the treatment with the last TKI before the downgrading had a median of 44 months, and the de-escalation of dosage prior to the downgrade in 55% of the patients due to extra hematological toxicity, and in 8% of the patient was to hematological toxicity. The TKI before downgrading was mostly nilotinib, dasatinib, ponatinib, bosutinib, and one patient with asciminib. The next one. And here we can see the drugs before and after the downgrading. And what's interesting to see is, and the conclusion mostly of this is that the TKI used for downgrading in 157 patients were imatinib in 67% of the patients, and then bosutinib in 25% of the patients. The reasons for downgrading were the adverse events, 83% of the patients, and the elective choice to avoid adverse events or reduce adverse events. This is something that perhaps in the common practice we do it. 15% of the patients downgrade because of that reason, and pregnancy 1%. There was no consensus on the potency of asciminib and ponatinib, as 4 patients were downgraded from ponatinib to asciminib and 1 from asciminib. The next one. Here we can see it's interesting here to see that, for example, at 12 months, we can see that 17 patients had achieved MR 5.0. So the post-downgrading molecular response at different time points, and the last follow-up showed, showed overall survival. Can you go back? Overall survival rates 84%, and the transcript improved in 33%, was stable in 51, and worsened in 5. So this is interesting also, that they downgraded, but mostly every patient improved 33%, and 51 was stable. The next one. The next one, because I'm not going to talk about TFR. So in this exploratory survey suggests that downgrading can be a safe option for a long-term CML treatment. In 51% of the cases, the molecular response remains stable, 33 improves without a higher generation treatment, reducing toxicity. Patients who reduce therapy after may attempt TFR also, although the number of patients is limited. There were 24 patients, I think. As expected, imatinib and bosutinib were the most chosen drugs for downgrading, and the most common exchange rates were nilotinib to imatinib, dasatinib to imatinib, or nilotinib to bosutinib. And these findings encourage expanding the case series and support future prospective study. And as generic drugs and new therapies emerge, documenting transition from potent to lower impact cost-effective treatments could enhance resource management, ensuring access to necessary care without compromising the quality. Perhaps this is it's a good conclusion for our region. That's all, I think. So I would be very glad if you would like to ask questions. Thank you.
Thank you very much, Carolina. I will take my screen down. Who would like to open up for some questions? Lillian.
Carolina, would you recommend starting with a more potent TKI like asciminib in low-risk patients like or in our reality in Latin America? What do you think? Because it's more potent, but there are some adverse events that also are more serious.
Yes, I think we have so many possibilities today, being in Latam or in other parts of the world, that I think that we must think about each patient as unique and see the comorbidities of the patients, the SOCAL of the patients, or the risk. You are asking for a low risk patient, and really I think that for the asciminib results are very encouraging. I think that we need a little bit more time for low risk, perhaps, patients. And I think asciminib, it's not for everyone, as dasatinib is not for everyone, and nilotinib, it's not for everyone. We are looking and we are thinking and having, I think we need more time, more longer time, more data in these trials to really see what happens in the next months or years about the adverse events and the mutations. I think it's an excellent drug, has an excellent safety profile, and has efficacy, a good efficacy. And when you say and you see this and you see the adverse event, we don't have to forget also that second generation TKI as nilotinib and dasatinib are excellent TKI, but we know a lot of adverse events and a very serious adverse events with this. So perhaps it's important to consider asciminib for adapted to each patient.
Katia.
Hi, very nice presentation. I heard that recently asciminib was approved in Argentina, right?
Yes,
in first line.
It has been approved in first line in December of last year.
Yes, it's very recent. I would like to ask you, how are you doing this? How are you putting asciminib in the decision tree? How is it in clinical practice now? Do you really have access or not?
No,
they're still working on the access?
Yes, it has been approved recently, but it didn't. We are not prescribing it because it has. It's really not for many doctors don't know even that it's approved in first line, because there has not been yet. I think in May there's going to be a meeting, and it's going to be the official communication. But but really we are with our group, of the Argentine group, with Ana, Beatriz, we are always talking about this, and we are thinking about how this is going to be recommended in the guidelines of the Argentine Society of Hematology. And as I said, really I am thinking with you, because as Lilian asked me before, we have not experience in indicating asciminib, but really I just see the results of the second line patients that are fantastic in relation to the adverse events. And I think that it's not asciminib for all, but it's we have to adapt for it patients. If we have a patient that perhaps can receive it, we perhaps must consider it, because we know, as I have mentioned in the first trial, that if that patient fails, we have an opportunity with a second generation TKI. So and perhaps that we don't know, that patients goes faster to TFR. We need more time. But it's going to be in the guidelines. It's going to be in the guidelines. You in Brazil don't have it, no, approved yet?
We have approved in third line, but we still don't have access because the reimbursement is not still ready. But we have it, but only in third line. I think they will try to approve in first line this year, but it's not yet. But it will be very interesting to see how are you going to make this decision to
Yes,
guide
I
how to
think-
use it in our country, because it will be very useful for us too in Brazil.
Yes, we are going to start. We must think it together with the experts and with the not so expert. We must talk and recommend. Obviously, what I have showed about the arterial occlusive events, really, perhaps one is scarce about it, but with the other also, but the other TKIs, we also know that also produce arterial occlusive events. So we need more time, I think, to conclude.
Yeah.
And talking of time, we might just take one more question here from AC Kisada in the chat before we wind up for today. AC asks, in your opinion, is there a risk of selecting mutations in the myristoyl pocket when using asciminib in the first line setting? Should we use it more for later line settings?
Yes, that really we don't know, because as I have said, perhaps we need more time of follow-up. But really, I think that what I have shown, most of these myristoyl pocket mutations, most of the resistance of asciminib were in the myristoyl pocket. So obviously, where the asciminib acts, digamos, in the pocket. So I think that these mutations were studied, and this is the first time we've seen them. But I don't think this would increase and would be a problem. But as I have said, I think we need to prove, we need to indicate it, and we need to have also NGS to detect these mutations, or Sanger sequencing.
And forums such as these, where you can all get together and share thoughts and views and what's happening in your practice, are really good for extending that knowledge. Thank you very much, Dr. Katia Pagnano, Dr. Carla Boquimpani, Dr. Carolina Pavlovsky, and all of you audience for joining us today and hanging in there, including our interpreter as well, who must be very tired by now. So we've run over time. That's it from me. Thank you very much. I will send links to the recording of this session along with dates, topics, and speakers for the next session soon. And do look out for a post-event package that we will send you tomorrow or over the weekend, just to try and extend the learning a bit more. Please visit our website, the Knowledge Centre. It's packed with great learning, and feel free to reach out to me if you need any help with any CML matter at any time. We're very well connected, as you can see. So that's it from me. See you at the next ICMLF key discussion on CML Latin America on the 8th of May. Thank you very much for joining us today.